Welcome back to Made to Be Whole. Stay tuned for this week's diabetes wrap-up. Made to Be Whole is intended for informational purposes only. It's not intended to replace the advice or care of a licensed healthcare professional. Participating in this podcast does not constitute a provider-patient relationship with Krista Michener, AHP Integrative Health, or any of the guests featured on Made to Be Whole. Krista Michener, AHP Integrative Health, and any featured guests aren't responsible for any losses, damages, or liabilities that may arise from use of information obtained in this podcast or associated materials. Please consult a healthcare professional for any health-related concerns that you are experiencing. This is Krista Michener. We've talked the last 3 weeks about diabetes, about intermittent fasting. I'll give you a bit of an update on Daniel, who you heard from last week. He actually let me weigh him because he doesn't ever really want to know what he weighs. And he's lost 40 pounds just by doing daily 16-hour fasts, which for most people is pretty manageable. And as we mentioned, he found a way to do it that fits the rhythm of his body. You know, he's a later eater anyways, and he's doing really well, and he feels better, and he said it really is not even that difficult at this point. So just throwing that out there for those of you who have tried different things or who get blindsided by the idea that something has to be really big to be effective. Not everyone may have it in them to do the 36-hour fasts, may not have the support or the emotional or physical wherewithal to do that, and I don't think they're for everyone, but we can all make adjustments. So my parents even, I was able to convince to try a modified version of this, just focusing on really not eating after dinner. And my mom's most recent A1C was down a point from before, and she had been struggling with it before. So again, minor tweaks. Part of why intermittent fasting is effective is because, as Brian mentioned, you get into this ketosis, which is really helpful. There are other ways to do that. One of them is the ketogenic diet, and there are a lot of variations on the ketogenic diet. So, some people go carnivore, do Atkins. You can even do a vegetarian ketogenic diet, which takes a little more effort and planning, but it's possible. But it's that general principle of basically flipping the food pyramid on its head, and not so much with the sweets and processed foods. Those still aren't high on what we want, but we want more of the fat. We want then protein, and what we want less of is the carbohydrates, the things that were supposed to be the foundation of our pyramid before we flipped it. There are also people who are already on medication for diabetes, trying to navigate which drugs to take and what not to take. I wanted to go through a little bit about available treatments, risks and benefits, and then look a little deeper into nutrient deficiencies that can affect blood sugar and insulin regulation. So metformin is old, it's cheap, it's a biguanide. That's the name of that medication class. And what it does is it lowers the amount of glucose produced by the liver. Brand name glucophage. It's not expensive anymore. Main adverse effect is GI stuff, even though the extended release for a lot of people offsets that. The next most commonly prescribed one as far as your generics are sulfonylureas, they're called. And that's your glimepiride, glipizide, glyburide, brand name Glucotrol for the glipizide. But basically, they're not insulin, but they're making the beta cells in your pancreas release more insulin. So they're having that same effect, increase insulin production, drop blood sugar. And even though it can be effective for reducing blood sugar, remember, high insulin is actually what's causing some of the complications of diabetes. So not really ideal. We also have some real safety concerns with sulfonylureas, especially for older people, because they can cause lows. And lows can cause dizziness, can cause cognitive issues, can cause falls. So you really need to make sure you're eating with those. What you see more of are the DPP-4 inhibitors, which are like Januvia, Tradjenta. Those are the brand names. a whole bunch of the generic names. They end with gliptin, though. And basically, they slow the inactivation of what's called GLP-1, and which lowers blood glucose levels. So they're okay. Again, they don't offset the risks that we talk about that come with diabetes and insulin overproduction and high blood sugar. If you remember, we can lower blood sugar, but if we're not effectively managing this insulin glucose balance, we're just driving the sugar into other tissues and organs, which can cause issues. Welchol is really interesting. It's a bile acid sequestrant. It doesn't get used very much for diabetes. I actually mostly use it as a binder for people who have mold illness. It lowers both your LDL cholesterol and your blood glucose levels. Cholestyramine is the generic name. It's kind of an interesting addition if you have multiple other things going on. I think it's great whenever I can find treatments that kill 2, 3, 4 birds with one stone and have a better safety profile. It comes in a powder, so that can be advantageous because you can really titrate dose. And then if you look at the SGL2 inhibitors, and those are pretty popular too, they basically keep the glucose from being reabsorbed by your kidneys, and then you pee out the extra sugar. So these meds are not a great idea for someone who's prone to urinary tract or vaginal urogenital yeast infections because that sugar can feed the yeast. But the brand names are like Forxiga, Jardiance, Steglatro. The generic names end in gliflozin, Gliflozin. They do good for some people, can bring down A1C a point or so. People will do a lot of things for weight that they won't do for their health. And I don't think weight and health are the same thing. People say they worry about their weight because they're worried about their health. But I don't really believe it for a lot of people because there are a lot of other things that affect their health that they don't want to do anything about. I think it's our vanity and our insecurity, and we care more about this than things that have much more lasting consequences. Weight to me is a symptom. You can be healthy and on the heavier side. You can be thin and incredibly not healthy. You can be on the heavier side and feel good about yourself. You can be skinny and hate yourself and think you're ugly and fat. We need to look a lot more at why our weight is what it is and assess if it's really a problem. Is it really affecting our quality of life? I just think we give it way too much energy. And I come from this partly from the point of view of someone who, as a young person, dealt with eating disorders. And I call it post-traumatic eating disorder, is that it changes how you view things, how you view yourselves, how you view food. And it's so disruptive. And I really don't think weight is that big of a deal, except in a few instances where it really negatively impacts things. I think even though you may have heavy people who have health problems, usually that's more a byproduct of diet and other lifestyle factors than the actual pounds on the scale, except in maybe a few cases. We talked a lot more about insulin and how insulin is not an ideal treatment for type 2 diabetes. It brings down blood sugar, but insulin, as we discussed at length, can do a lot of high insulin levels are what cause a lot of the complications of diabetes. So feeding yourself that insulin as a substitute for trying to make any lifestyle changes is not an ideal way to go. There are some changes recently in legislation and cost. Insulin's been around for a long time. There's no reason it should cost as much as it does, but you've got to kind of follow the payroll. I was doing continuing education a few weeks ago where the speaker was a physician who was talking about the ketogenic diet and how it was first discovered in the early 20th century to be an effective treatment for treatment-resistant epilepsy, which is someone who has seizures. Fell out of favor with the development of some medications. And even now, you really have to push to find someone who guides you into that. Now, when you're looking at something like epilepsy or some of the other neurological conditions that ketosis is helpful for, the intermittent fasting isn't really the way to go, because you can have periods of it with intermittent fasting that you're not in ketosis. And to have the benefits for managing seizures, you need to be in ketosis all the time. So you would really want to seek some medical guidance on helping someone come up with a safe ketogenic diet. But if you dig into the history, there's a lot there. The reason I went on that rant is the speaker made a very, very interesting statement. He said it is very, very difficult to get funding for interventions related to nutrition. So that would include intermittent fasting, even though we've got good evidence. That would include ketosis. That would include anything dietary to treat illness and to treat the root cause. And if you think about it, when people make nutritional changes, nobody is going to profit off of that other than the individual whose health is improved, whose quality of life is improved. And there are a lot of people who stand to lose. I really don't think that everybody has some nefarious purpose for the career path they're in or for every drug that's developed, but I do believe that, generally speaking, you would be foolish and ignorant to say there's not a lot of financial incentive to keep people chronically ill. Because if you take a medication for chronic illness, you have to take that forever. If you have to see a specialist to manage a chronic illness, you have to see that person forever. You're at the mercy of procedures and pills. And heaven knows, I am glad to be alive today where we have so many good interventions for things that there didn't used to be help for. But I'm also really disappointed to live at a time and be part of a profession that fuels that fire and feeds those lies, basically. There's a lot more that we can do to find root cause and to heal people. There's always going to be a challenge or challenges, because you have a mortal body, you live in a fallen world on a toxic planet. It's not going to be perfect, but there's so much more that we could do that's really not as expensive as what we're doing now. And if you think about the arguments that have been made about healthcare and getting medication to the poor and access for the poor, which I absolutely do think everybody should have access to good primary healthcare, but even that is just feeding medications. Think about fasting. Fasting's free. It's absolutely free. It doesn't cost you anything. As a matter of fact, it might save you some money because you're not eating as much. That is the best thing we could do for anyone of any socioeconomic class, is to teach them those principles, things that they can take control into their own hands. I hear a lot along the same lines of people saying, oh, nutrition, that's kind of weak interventions. You hear the same thing about supplements and how dangerous they are, and they're not regulated by the FDA, and oh my goodness, we don't have the studies that we have on these great meds. But we do actually know a lot about what nutrients do as far as the Krebs cycle, which is energy production, but also the body's ability to function properly on all sorts of different levels. I've talked before about how I like intracellular micronutrient testing, and SpectraTel is one of the tests that I use. And they've got some really good educational stuff on their website, but they have all of these correlation charts specifically that I would invite you to look at. You can search for anything. You can search for diabetes, cancer, hypertension, stroke, and they will point you to research. But then also they have these wheels or charts that say, here's the condition, and here are the nutrients that have been found to affect that. And I wanted to go through some of the ones that I see most commonly with diabetes. Again, yes, you can order a bunch of these things and take them. I still think it's worth your money and that you will save money in the long run by getting good testing to see what exactly is your body missing. So as far as nutritional deficiencies that are correlated with diabetes, one that's fairly well known is chromium. So chromium helps insulin attach to your cell's receptors, increasing glucose uptake into the cell. So if you don't have enough chromium, the body's more prone to develop that insulin resistance, which is the hallmark of type 2 diabetes. And there have been trials that have shown benefits for type 2 diabetics. So chromium. Now, with a lot of nutrients, you really want to look at cofactors. So that's why working with someone who can look at everything and how it goes together to get you the best outcomes, not just, okay, I'm going to order a bottle of chromium. That might give you some benefits, but you've got to look at the whole picture. So having adequate vitamin D levels actually lowers the risk of type 1 and 2 diabetes. And vitamin D is anti-inflammatory when you get it to the right level, and it can suppress inflammation of pancreatic beta cells. So there are vitamin D receptor genes that are actually linked to diabetes. And vitamin D, that's pretty low-hanging fruit. Most people can get almost any provider to order a vitamin D level for you. And what you're looking at, if you are not taking, or not doing, the intracellular testing, you're just doing your regular LabCorp, Quest, whatever tests, you want to get that level to at least 60 because that's where it becomes anti-inflammatory. The guidelines say that you're not deficient unless you're under 20 and that you're insufficient if you're 21 to 30. But pray tell, what is the difference between 31 and 29? Nothing. You really want to drive it higher. No, vitamin D is not dangerous. Is it technically possible to take too much vitamin D? Yes, that is technically possible. It's a fat-soluble vitamin, but it is pretty difficult. There are very few people who cannot safely take 5,000 units or international units, which is 125 micrograms of vitamin D daily. So vitamin C has been shown to have benefits in lowering A1C and your fasting blood glucose as well as glucose levels post-eating in type 2s. Carnitine reduces and can even prevent pain from diabetic neuropathy. But as far as like the actual disease itself, not just the damage, it improves insulin sensitivity because it increases glucose uptake and storage. It's a protein. I've had several people recently come back to me with low carnitine levels, which I've found to be interesting. Lipoic acid, sometimes you'll see alpha lipoic acid. It increases or enhances, glucose uptake in your skeletal muscle tissue and improves glucose tolerance in type 2 diabetics. It can be super helpful if somebody has diabetic neuropathy. We talked a few months ago, I guess it was, when we were talking about our B vitamins, about biotin, which is vitamin B7. People typically think of this as your hair, skin, and nails vitamin, but it stimulates glucose-induced insulin secretion in your pancreatic beta cells, and it can improve glycemic control if you're using enough, the right doses in some diabetics. Deficiencies of magnesium reduce insulin sensitivity, and people who have low levels of magnesium and have diabetes are more vulnerable to have ulcers. Zinc is needed in the synthesis, storage, and secretion of insulin, and also protects pancreatic beta cells. So another just very low-hanging fruit. Glutathione and cysteine, these are critical for everything, but glutathione is the body's master antioxidant. Cysteine is an amino acid that's a precursor to glutathione production. But glutathione-containing enzymes protect beta cells, which are particularly sensitive to oxidative stress. Type 2 diabetics have abnormal antioxidant status, so you can help restore those levels. Yes, you can take glutathione, but you can take cysteine, or N-acetylcysteine is particularly the form we usually recommend to boost glutathione production. Other things that boost glutathione production include sulforaphane or sulforaphane-containing supplements like Avmacol. as well as there's a really good product called Immunocal, which is a purified, like high cysteine milk protein, and it's fascinating. We could spend a whole episode on that, but they've shown it to be really helpful in improving outcomes in cancer, in ICU patients with respiratory issues. It's just a really effective form. CoQ10 protects your kidney from diabetes-related damage and can improve glycemic control in type 2s. So when we think about diabetes, we're thinking about the actual disease itself, which is with type 2, hyperinsulinemia, too much insulin, and this develops insulin resistance, and this is in response to too much blood sugar, which is primarily diet related. But you could see how these deficiencies can really help prime the pump, because if you think of a factory with some workers who don't show up or are only doing their job part of the time, things aren't going well on the assembly line. If you think of a clock with some of the gears missing or broken, it's not going to tell time as effectively, and eventually it's just going to sputter out and die. I love glutamine. Glutamine is an amino acid, and it stimulates GLP-1 that regulates insulin secretion after meals. If you go back to the medications that we were talking about, the GLP-1 receptor agonists, which are the like semaglutide and other medications, are working at that receptor as well. Well, why don't we take some glutamine if we're low on it and see if we can't help that process work better? Inositol can help in treating diabetic neuropathy. Vitamin E can give you some prevention against diabetes by protecting those pancreatic beta cells from oxidative stress, and it can also help the progression of type 1. Vitamin B3, which is niacin, can preserve beta cell function. And then vitamin B12, I think this is interesting. Metformin, super commonly prescribed, but metformin depletes your vitamin B12 levels. So I always wonder with some patients if their neuropathy is diabetes related, or is it at least partially related to a deficiency that we created with the medication that we use. So, and I'll always remember the story because it was when I was studying for my NP boards, and we were taking a board review class, and it was actually really good. And that was the first place that I learned that metformin can deplete B12. And I hadn't been taught that in school. I hadn't been taught that in pharmacology, even though we studied metformin and diabetes treatment extensively. And I remember the teacher, who was actually excellent, being asked, "Oh, so should people on metformin just take B12?" She goes, "Oh, no, just watch their levels, and if they develop a deficiency." That to me is mind blowing. If you're on metformin, you should be on B12. If you're on a statin, you should be on CoQ10. We've got to look at the damage we're causing with these medications like PPIs, proton pump inhibitors, that are widely prescribed for acid reflux, even though they were never intended to be taken long term. But they deplete your magnesium levels, which can affect bones and are associated with increased osteoporosis risk. So again, the downstream effects of some of the treatments we're doing are substantial, and we need to be looking at risk benefit. And in the context of diabetes, which started this conversation, what I would encourage people to do, you do not have to, if you're on medication, run and stop it. I don't think all medication's bad. You've got to do things in an intelligent, organized, educated way, and find people who can help you safely make changes. If you don't want to be on medication, figure out what lifestyle changes are sustainable for you. Can you walk 150 minutes a week? That's been shown to improve glycemic control. That's super important. Can you do modified intermittent fasting or some other form of a ketogenic type diet? Slow and steady wins the race. And if you've been dealing with this forever, it's not going to get fixed overnight, even though you might be surprised how quickly it can get fixed. One of the interesting things that Dr. Chung mentions in the book, The Diabetes Code, that we discussed, was how gastric bypass surgery has been shown to cure diabetes. And pretty rapidly after gastric bypass surgery, people can be off insulin and off medication. Why is it? Is it because part of the body was removed or rerouted? No, it's because somebody has forced fasting. When they first have that surgery, they basically can't for a period of time, and they're not taking in carbohydrates and all of these things. And so by forcing the body to fast, they're getting off meds. I would propose that you're going to be much happier with your life if you can find a way to do that without having your insides sliced and diced, because there are a lot of long-term consequences from that surgery, including some of these nutrient deficiencies that we're talking about, because you're removing or bypassing the parts of the gastrointestinal system that absorb certain nutrients. And also, for those of you who don't have diabetes, you're not destined to develop it. Yes, there is a genetic component even to type 2, but remember, it is not a death sentence. It just means you may be more vulnerable because of your genetics, but if you act sooner rather than later, you can prevent that from happening. I know that one of Daniel's big motivations is he does not want to have diabetes. He's seen the way it's affected extended family members, and he wants nothing to do with it. And you do not have to sit and be content to be afraid or to be ignorant just to hope it doesn't happen. There are literally very important concrete things you can do to help mitigate that risk. Nobody was intended to be ill, and none of us were intended to be on massive amounts of medications. So just remember that we were all made to be whole. That's the point of this podcast and what I do. And be patient with yourself and don't be afraid to keep digging for root causes. One other thing I will throw out there before we wrap up about diabetes, something that you should be super, super aware of, anyone who has flares in blood sugar. If you've got these lapses in glycemic control and you don't know why, you really should look for infection. I've seen this many, many, many times. I have an extended family member who had been to the ER with GI problems, was told that they were just constipated and to go home and take more Miralax. But this individual's blood sugar kept getting higher and higher and higher. And I knew for this person that higher blood sugar usually meant infection. So anyway, I rechecked labs. The white cell count was even higher, which is a sign of infection. We ended up back at a different ER, and that person was septic because they had a perforated bowel. And the advice they were given was to take more Miralax and drink more water. I just can't even sometimes. Same thing happened with my mom recently. Her sugar was just struggling. She developed cellulitis, which I think had been bubbling for a while. We treated the cellulitis, discovered a UTI. Sugar's back down to where it should be. So don't beat yourself up. Just try to think, try to analyze what could be going on. If you haven't changed your diet, if there's nothing else that has altered and suddenly your blood glucose levels are much, much higher, think about what could be driving that, and infection very, very commonly can. So remember to never give up in your search for health. Never accept a lifetime of drugs without digging to see what else might be available to you. And remember to have hope, because you were made to be whole. Have a podcast question or suggestion? Text or call us on the podcast info line at 330-439-0686. Thank you for spending time with me today. If you like what you hear, please subscribe to be notified when new episodes release. And remember, you were made to be whole.